Hello and welcome everybody to today's Youth Care podcast. My name is Oliver Grundmann and it is a great pleasure to welcome Dr. Sara Nixon to the podcast today. I'm sure you all know her, you adore her, you love her, and I look forward to having a really great discussion with you, Dr. Nixon. Would you mind introducing yourself to our audience?
Not at all, and thank you for having me. I think this is going to be great fun. I am the director of the UF Center for Addiction Research and Education, and I'm a professor in psychiatry, in neuroscience, and psychology. And I am the director of the Neurocognitive Laboratory.
That is a lot of responsibilities you are having on your back, but I think you are well known within not only the UF Care community, but also beyond for much of your research that you have conducted over the decades, we have to say, and the accomplishments that you have worked on. So when you look back on your trajectory, where you are now, and when it all kind of started for you, how did you actually get into this area of addiction research?
Yeah, I think about that periodically. Because when I was training and shortly thereafter, I did not intend to do addiction-related research. I was going to do cognitive studies of, this and that, but nothing clinical and certainly not about addiction. But sometimes things come around when you don't expect them. And I was in university administration, yearning to get back into research. And I had the opportunity to do a postdoc with Dr. Oz Parsons, who was sort of the grandfather of the study of neuropsychology and alcohol use, misuse, and addiction. And I didn't realize he was famous, or I probably would not have gone to work with him. I would have been terrified, but I had the chance to train with him, and I found I loved it, that the study of addiction science was really about all kinds of science. It wasn't a niche, but rather opened the door for a lot of other things. So that's how it happened.
That is awesome. And obviously this inspired you to mentor generations of students thereafter and get them hooked, so to say, on addiction research themselves.
Yeah, exactly. And I'm very proud of them. So many of them have continued in the field and have done really well, and they are delightful people on top of all that.
That's awesome. Yeah. So when you look at your trajectory, what I said at the beginning, and you started off in the area of addiction research with alcohol use disorders, and then from there things changed and branched out as you explored potentially new areas. Where is your current research focused on?
Oh, that's a harder question than it should be. Right?
Well, you can break it down.
Because I like doing a lot of different things, preferably all at the same time, right? That's a good thing. And it's hard for me to say because our work really is a team effort. Everything we do, from writing a paper to drafting a grant to the actual implementation of a study, can't be done by one person. And furthermore, it benefits from the input of these minds, having thoughts and opinions, and also doing a different kind of reading. So our work right now has multiple branches. We've completed a study in which we looked at cognitive retraining in individuals who were seeking treatment to look at cognitive recovery. I've been writing about cognitive recovery for, as you unfortunately said, decades. And we had the chance to put some of that to work in a grant and have some interesting findings looking at the role of emotionality or not in cognitive recovery. We also have done in recent years a lot of work in aging, and that work has centered on the effects of acute alcohol in older healthy drinkers and younger healthy drinkers, and exploring the processes by which response to alcohol may be different in the two groups. For the longest time, it's sort of been assumed that, well, yeah, because metabolism is different in aging, and so you achieve higher this and that and the other. But we did some really well-controlled studies that we were even surprised by, where we were able to target particular breath alcohol levels and achieve the same level in older and younger adults, and still got significant differences in terms of underlying neurobiobehavioral processing. So that's been really fun. And we found out just yesterday that we have a new grant that will be focusing on, yes, indeed, that is going to be focusing, it's a longitudinal study with older adults that will be following for 3 years to try to look at the impact of the social components of the COVID pandemic, not the medical ones, but the isolation, the physical distancing, all of that sort of thing, how that impacts various components of health, but also use of substances, and then how those factors interact over time.
There are quite a few, I think, amazing topics, because the implications obviously are already there. When you think about, if I may go back to cognitive recovery, because some folks may not know what that entails. It sounds like a little bit of a squishy term to me. Can you define it a little bit?
Yeah, yeah, we like squishy. That's a scientific term. Absolutely, absolutely. So my earliest work, and really most of the early work in the field, had to do with trying to define what were called cognitive impairments or cognitive deficits observed in individuals, typically it was alcohol at the time, who were now detoxified, but seemed to still demonstrate subtle but significant detriments in certain kinds of processes, although it seemed to be pretty much across the board. From there, our lab began to shift the focus from, gee, what exact component? Is it just memory, or is it something in this lobe, or what we call locate the lesion? We moved away from that, encouraging consideration of cognitive efficiency, which is really what we use in the real world. We make trade-offs between being how fast do we need to be, how accurate do we need to be? And we do that in almost a compensatory manner. So we began studying this efficiency concept rather than a particular performance on a particular task. That led us to think, well, we know that individuals actually, that some of these cognitive deficits improve with time, with abstinence. We know that. I wonder if and that's sort of the recovery piece. So we wondered if we could hurry that along by giving intense training even while people were early in that recovery process. And so what we found is that indeed they have very nice learning trajectories. And we also found that if we train them with emotional stimuli, it was a sort of a complex working memory task, but we had faces in it that were not very happy sometimes. If we trained with those kinds of stimuli, it generalized. So that then when we tested performance on a traditional neuropsych test, the emotional Stroop, guess what? They did better than their counterparts. It was a very interesting sort of, it matters. Training helps. Not only that, but the type of training can matter as well.
That is fascinating. So it is another component yet of the complex therapy that we should consider. I mean, you potentially did it focus on one substance use disorder, alcohol, but can that be, do you think that can be generalized to a range of substance use disorders when it comes to shortening the recovery and regaining cognitive function back to baseline, or a non-substance use disorder affected person.
Right. So these data can't speak to, does it reach the peers, right? It was, or the community control level. Ultimately, that would be sort of your goal, right? But really what we want to do is say, can we facilitate this recovery such that they're in a better place to face the challenges outside treatment, right? The barrage of things that happen that require quick reflexes or working memory, or remembering what you're supposed to get at the grocery store. All of those things count on these basic processes. Now, about multiple drugs or not. So one of the things is that the idea that individuals use just one drug applied a long, long time ago. And even then nicotine was a major comorbid use, right? Nicotine and alcohol. Well, now when we go in and we say we're studying alcohol in the context that the individuals that we engage in study meet criteria for an alcohol use disorder. That doesn't mean that they don't meet criteria for another drug disorder necessarily, or that maybe they don't meet criteria for those other disorders, but they fulfill some of those criteria. So you have to be very careful anymore when we talk about that. And we try to be clear about the fact that, yeah, they met alcohol use disorder. That doesn't mean they didn't use other substances as well. Nicotine is used by about 80% of individuals who seek treatment for an alcohol use disorder.
Wow. So it really boils down then that this becomes a component of the complex treatment regimens that we try to individualize and help individuals to along on their road to recovery and not falling back, not recessing into their old habits, so to say. So it is kind of an additional point of therapy that can benefit patients.
We would hope so. Yeah, I was thinking about that very point earlier when I was thinking about this interview, and the idea that one of the things we hope all of this would lead to, particularly the idea of, can we train this? Can we improve that even while people are early in recovery? Is the fact that if we are going to move the field forward in terms of clinical implications, one of the things we need to be able to do is identify, develop, and implement an array of treatment opportunities so that it can be better individualized and meet those needs. There are some people who come into treatment and do not have cognitive deficits. Now, 50 to 80% of the individuals we test do, but that means the others don't. Between 20 and 50% do not, right? So would cognitive training do them any good? Maybe not, right? Maybe something else needs to be a component of that. We often think of these deficits as being sort of in cold processing areas like working memory or visual spatial processing or abstraction and problem solving, but we've also done work with more sort of realistic tasks like interpersonal problem solving. And certainly individuals often do not go to treatment because they don't perform well on like the trail making test, right? Which is a standard neuropsych test. They end up there because of interpersonal problems, work-related problems, these kinds of things. And we did an interesting study about a long time ago. And then we replicated it just recently using this, what was called adaptive skills battery. And in it, it's a series of vignettes, and you ask them, what is the typical thing you would do? And then in a separate set of vignettes, we asked them, what do you think is the best thing to do? Right? And we found that when we compared age and education equated community controls with individuals who are in treatment, guess what? They performed the same on the best. But the people in treatment had a harder time producing responses in typical situations that were most appropriate. So, it isn't just in these cold things, it's in these warmer interpersonal kinds of relationships that we could work on. That's, yeah.
So they wanted to reach the same best, that they wanted to get there, but they were currently stuck in a different.
I mean, that's certainly what those data look like, because it's like, I know what's best, but I don't produce what's best. Well, then how do we help you do that? Right.
So I wanted to briefly go back to your latest work in regards to COVID-19, because I think has been on everybody's mind for now 2 years plus potentially. And it is obviously emerging work that kind of reflects on where do we stand as a society and how are particular groups of people differently impacted by COVID-19. It sounds to me like your study is very much at the heart of substance use disorders, how people may turn to substances during COVID-19, and how those who already have a substance use disorder are affected by COVID-19. Can you get a little bit into that?
Sure. You've set the groundwork very well. There's been a lot of concern about that sort of thing. What hasn't been teased apart is that much of that is done at the population level. There's sort of epidemiological data, which are terribly important, but it's really hard to tease out processes. How did it get from here to here? What happened in between? So we know that isolation, we know sleep disorders, we know mood, all of these things, and they fit together in a bidirectional way. So that what we would call those are sort of distress measures. We are particularly focusing on the possibility that the requirements of social isolation interface with these other things, which in turn interface with substance use, so that perhaps over time, as we watch these trajectories change over time, which they'll probably change with, how many variants are there? How long do we have to? How much consistency is there in how we as a society are approaching this, right? So that you're going to get to go to your bridge group every week, or you're not going to get to go to your bridge group every week. These kinds of things change over time. We can follow those trajectories with our model so that we include individuals. We follow them over 3 years. We look at the interaction between them using a pretty complex statistical model that will tell us about differential trajectories, individuals who seem pretty immune to these things going on around them, and those that are particularly vulnerable to them.
That is interesting. So you kind of also then looking at what could be specifically under COVID-19 conditions, impactful or contributors to that lead somebody to engage with a substance.
Absolutely. Absolutely. Yeah. Right. So where did their use start out here, and how does that vary across time? And can we predict that from the variables we have, or is it outside this set of variables? Maybe it has nothing to do with COVID-19. Maybe it has nothing to do with these things. I think it will, obviously, but we can tease those apart. It's going to be really fun.
Wow. Well, I definitely look forward to work that emerges from that and publications, because I think we have all been, to some degree, everybody has been impacted by COVID-19. I feel very certain about that. But then especially vulnerable populations in regards to substance use disorders are important to look into. So I wanted to drive it back a little bit to your role as the director of a U.S. Center for Addiction Research and Education. And you are obviously very passionate about that, as many other youth care members are as well. But what is kind of your current major focus of youth care, and where do you see it going in the next year or so?
Thanks. We have grown tremendously since 2018, when we became the center that we are now, but we have much more to do. Our primary mission is to facilitate collaborations and to facilitate the conduct of excellent addiction science, while also supporting training of excellent future addiction scientists, right? And we can do that in a variety of ways, but we can do more. We already do travel awards and some dissertation awards, but we're moving forward. And in the other room here, they are putting together and they are gathering pilot data from a piece of shared equipment, which is a magnet-compatible EEG system. And by combining those and making them available to not only the UF Care scientists, but the larger community on campus, we can help benefit, support all of those things, the science that uses human imaging, regardless of its particular background. So being able to participate in that sort of shared mission is a part of what we want to do. The other is that depending on, obviously, we don't directly get any state funds. So depending on the financial end of things, we would like to begin doing pilot projects or bridging grants, even for faculty who may have a glitch between their current funding and what's anticipated, or new faculty who need a way of getting started, that sort of thing. And the other is to make sure that our scientific programming remains diverse. So we do the monthly seminars, we alternate the basic science with the more applied science. I think that's a real strength because you get to learn on either side of that. And we do the same thing with the annual symposium. More ways of doing that, I think, could be really beneficial in helping us appreciate the breadth of addiction science.
So you hinted at the annual symposium. Do you want to say a little bit more about this year's annual symposium?
Of course I do. Of course I do. Yes. The annual symposium is April 4th. We're doing it by Zoom again, and for multiple reasons. But last year, by doing it via Zoom, we had a national audience. Participation was great. It became evident that people were indeed paying attention to the programming going on here, and if given the opportunity, taking advantage of it. So that was very exciting. We have 2 keynote speakers, as we always do. Our more basic presentation will be given by Dr. Marina Picciotto from Yale, and our more applied will be given by Dr. Suzanne Colby from Brown. But throughout that entire day, we're doing different kinds of events, data blitzes that are open to undergraduates through faculty, small talks, short talks that will be primarily senior trainees like postdocs or junior faculty, giving them a chance to present their work to a large audience. We'll be doing roundtables roundtables, I'd call them, not workshops. Roundtables that have to do with career development may range from everything to setting up a lab to how do I interview and not screw up? Well, I would say don't do it by Zoom. That's what I would say. And then the other part I'm very excited about in that in this effort, we have collaborators from across the state. And so we have collaborators from Florida State, from the University of Central Florida, from the University of South Florida, from FIU, and this year from Scripps. And those faculty and their trainees play a role in this as well. So one of the presentation sessions that we're going to have are presentations by these institutions about the addiction science programs at their institutions. And that will facilitate, I think, greater collaboration and discussion sharing across the state of Florida. I think it's going to be a great day.
Yeah, from what it sounds like, it certainly will be, there will be something for everybody who is even just tangentially associated with addiction research. And I think a lot of people in clinical practice kind of look at that because it unfortunately is quite common to encounter a patient with substance use disorders. So that's something that I really look forward to, and thank you for explaining that a little bit more in depth. Maybe we can use part of this discussion as a clip for advertising because you did such a great job.
That'd be great. That'd be great. Wonderful.
Dr. Nixon, any last words before we end this podcast?
No, I want to thank you for your patience, because once you get me talking about the science we do, I hardly ever shut up. And I appreciate the opportunity very much.
Well, Dr. Nixon, it was a pleasure talking with you. And I think your enthusiasm for this research kind of rubs off on a lot of people, obviously. It has already, and it does so within U of Care. So thank you for taking the time today to talk to us and to the whole audience of U of Care.
You bet. Thank you very much.
Okay, bye. Bye, everybody.